So, hi everyone. Welcome to another episode of Unpacking Possibility. I'm your host, Traci Stein, as always. I'm so happy to be here with you. I'm so happy to have a very special guest here today who's going to talk about something that has affected so many people, myself included. He'll talk about long COVID. My guest is none other than Dr. James C. Jackson, otherwise known as Jim to his friends and colleagues. I'll tell you a little bit about him, and then I'll let him tell you more about his work. So Dr. James Jackson is an internationally renowned expert on long COVID and its effects on cognitive and mental health functioning. Dr. Jackson is a licensed psychologist specializing in neuropsychology and cognitive rehabilitation. He's a research professor of medicine and psychiatry at Vanderbilt University, where he's also the co-founder and director of behavioral health at the award-winning ICU Recovery Center. And that's one of the first comprehensive clinical resources devoted to diagnosing and treating survivors of both mild and critical illness, including those who survived COVID-19. Dr. Jackson is the author of over 150 scientific papers in leading peer-reviewed biomedical journals, and his research has been highlighted in the pages of publications like The Atlantic, Newsweek, The New York Times, Scientific American, Time, The Wall Street Journal, The Washington Post, and Wired, as well as CNN and PBS, among dozens of others. His new book is Clearing the Fog: From Surviving to Thriving with Long COVID, a Practical Guide. So we'll get into more about that now, but Jim, welcome. Thank you for joining me today on the podcast.
Yeah, thanks, Traci. It's a cold day in Tennessee, but this will be a warm highlight for me. I don't really know you, but it's clear already that you're really delightful, and I'm glad to have an opportunity to engage these issues with you.
Oh, thank you, and likewise. Long COVID, I think, is such an important topic. I've been following, a lot of scientists on formerly known as Twitter and other places. I have had my own patients dealing with long COVID related symptoms. One of the things, maybe we should start by saying, having you describe what it is long COVID. How would you define long COVID?
Yeah, sure. It's a really good question. There was a famous Supreme Court case. People will remember this anecdote, I think, and it had to do with the definition of pornography. How is pornography?
I knew you were going to say that.
Yeah, and you'll remember, I think, because this is a famous case and a famous anecdote, that that the conclusion from one of the justices was, I don't know how to define it, but you know it when you see it. And I think that's somewhat true of long COVID. We've grappled with ways to define it in a very, very academic definitions that are more practical, perhaps, and everything in between. I don't know that we have come to a pithy consensus definition, but I would say as a clinician, perhaps you'd agree, you know it when you see it. In general, long COVID refers to a situation where you contracted COVID. Typically, we see this in relatively mild cases of COVID. And on the heels of that acute infection, there are the development of brand new problems, worsening problems that didn't exist before. Those include things like brain fog. That's a term with problems of its own. We don't necessarily know how to define that. Those symptoms include things like profound fatigue, problems with balance. I could go on. They're a huge range, but the gist, I think, is you are functioning normally, you're whistling a tune, you're doing whatever you do, you develop COVID, the acute symptoms go away, and you find that you have lingering problems that you didn't have before. That's what we're referring to as long COVID.
Yeah. If we had a week, there would still be more to talk about with this. It's going to be challenging to even be concise about it because it is such an important topic. It is a very significant public health problem. And, just as a quick aside, for many years, my primary patient population that I worked with was chronic pain patients. And I feel like, as somebody with long COVID and the people I've talked to with long COVID, there are some similarities there. Among them that, it is characterized by, for me, social, occupational, recreational, even spiritual challenges. Challenges to one's identity. In the social realm, just having people understand that you can look pretty similar to how you looked before, like a normal, relatively normal person, and be struggling to get through your days.
Yeah, this is a theme that we hear again and again and again, and that is people tell me I look fine. People say, "What's the problem? You look vigorous, you look healthy, whatever, you sound fine." And I think what often happens is people with long COVID, not always, but usually in a snapshot, they can prop themselves up pretty nicely. They can sit up straight in the chair. They can focus in a conversation in an engaged way. They can walk from the car to the grocery store and back. They can do that in a snapshot. But if you're not interested in a snapshot, if you're interested in what the arc of an entire day looks like, then you quickly learn that there are problems that emerge, right? They're impactful. People can hold it together for a time, but often only for a time. And what often happens, holidays would be a good example of this. Family members swoop in from out of town. They haven't seen you necessarily. They share a meal with you. You look okay. You're participating in conversation, and they wrinkle their nose and they raise their eyes and they say, "What's the matter? You seem fine." And people take a lot of offense at that. One thing we're trying hard to do with patients is to invite them to find ways not to be offended by that. I think it's normal enough to take umbrage at that. Often, the mother-in-law, the father-in-law, the neighbor, they're not trying to be difficult. They really don't understand. It's quite a conundrum, but it's a problem. It's what people with mental health difficulties, I think, have faced for a long time, right? Which is,
Absolutely.
how can you be depressed? You look pretty happy at that party to me. How can you have OCD? You're not rearranging things on your desk, right? All these silent symptoms that people have been carrying around that are hugely burdensome. These are the symptoms that long COVID patients are grappling with. And I think in total, this dynamic causes them to feel very misunderstood and also dismissed, particularly when the people who are saying, "You actually seem fine," are the physicians that are supposed to know better, right? And that's a common phenomenon, Traci.
Absolutely. And again, that's another parallel with chronic pain that, or chronic fatigue syndrome and other things that are, you know, largely invisible and a lot of healthcare providers really don't understand. I think in the case of long COVID, it's because it's also so much newer.
Right. It's because it's newer, and I think it's also the case. This is something we struggle with, frankly, when we engage with disability insurers. A lot of our patients are pursuing long-term disability, let's say, and I often, with our patients, have what are called doctor-to-doctor reviews. I'll talk to a disability company doctor, and I'll make a case for why John or Jane, is indeed disabled. And often the doctor will say, here's the problem. They were never really very sick. They weren't even in the hospital, much less the ICU. And I think there's this notion that you can't really be impaired on the back end unless you were, in a hospital bed on a ventilator for, 3 months on the front end. And I think that really reflects a misunderstanding of how long COVID works. It is mysterious. There are a lot of questions. There are a lot of mysteries, I think, about long COVID that haven't been answered. But one thing we know is that you can have a mild or even a very mild illness, and the consequences of that can be quite profound. Research supports that, and the experience of our patients support that time and time and time again.
So true. You really hit the nail on the head. I wrote down a million questions or things that for us to talk about. Maybe a good place to start too is, what are some of the most common symptoms you're seeing patients present with? The most common and the most bothersome, because they may not be the same thing, or the most difficult to manage.
Yeah, they might not be the same. It's really interesting what the symptoms are with a given patient that they tend to key in on or that they tend to be impacted by. I think there's a huge variance there. I used to work at the VA, our local VA hospital. I still do, but used to do disability exams there. And frequently, a lot of the veterans that I saw experienced ringing in their ears. They'd been on the gun range, they'd been on the firing range downstream. They had damage to their ears. Their ears were ringing all the time. And it was a curious thing always that some of them were not bothered by that a bit, and some of them were bothered by that a great deal, right? And I think we've noted that with long COVID, that some of these symptoms, especially the idiosyncratic ones, may not be hugely bothersome to some, but they may be profoundly bothersome to others. Ringing in the ears is a good example, right? I think everyone is bothered by profound fatigue. I think most everyone is bothered by cognitive impairment, but there's really a range with regard to what impacts people. And it has a lot to do, I think, with things like life stage. So, for instance, if you're having problems with fatigue and you feel quite weak in the context of long COVID, but you're 84 years old, that's one thing, right? If you're having problems with physical vitality and vim and vigor, and you're 32 and you have little kids that you're used to throwing up in the air, that's a different thing, right? It's much more impactful. Equally, if we take cognitive impairment, which is one of the really meaningful problems that people with long COVID have, if you're working in a job as a mechanical engineer, if you're a constitutional law attorney who is having to formulate complex arguments in real time and rely on that processing speed in front of a judge, you really need that cognitive intactness. If your job is working at a factory on an assembly line where your work is sort of rote in nature, it's a little less important. So there's this complex interplay with regard to what people find to be problematic. The unholy trinity that I like to refer to in long COVID really is cognitive problems, fatigue, and then the third leg of that stool. I know I'm mixing metaphors a little, but the third leg of that stool is mental health problems. I think mental health problems, and those problems include anxiety, often depression, not infrequently PTSD. It's certainly not the case that that those issues are the cause of long COVID. Too often, that's the message that people are sent. Right?
Yes.
This is just your anxiety that is driving these physical symptoms. I really want to be careful in dispelling that. But I think the truth is, if you're now cognitively impaired, if you're now too fatigued to play with your kids, if you now have been diagnosed with 101 things, you take a dozen medications every day, you've got meaningful questions about your financial future, your health, your job, it's very logical, I think, that you would develop major depression. It's very normal that you would develop generalized anxiety. It certainly could be argued that getting COVID is a traumatic situation, so you may get PTSD. So I think one difficulty I have had at times, and one area where I'm working hard in our support groups, is to try to highlight for our patients that these mental health problems are nothing to be ashamed of. Right now, our society sends a different message. I think that's changing some, but still our culture is not quite there. But I think it's really important to say to our long COVID patients, of course you're anxious. Why would you not be? Of course you're depressed. If I were in your shoes, no matter how many tools I've got, I'd be depressed too. I think that's a really important message because often they carry around deep reservoirs of shame related to the mental health difficulties they have. When I think as psychologists, we know that these are actually normal responses to an abnormal situation.
So well said. As you're talking, I'm, seeing kind of this movie, this carousel of images in my mind about, people, not only patients, but even friends and acquaintances or their family members, many of whom are not necessarily putting this in a long COVID context, by the way,
Totally.
but people who had pre-existing mental health issues that have become considerably worse.
Right.
People who have developed new mental health issues but can't pinpoint even like a feeling of traumatization from having, severe long COVID or anything like that. But mental health symptoms that are unmanageable or not, or very hard to manage. I wonder if you could talk a little bit about what is happening in the brains of people who are dealing with long COVID and reporting things like brain fog, problems with word retrieval, problems with processing speed you mentioned, and things like that.
Yeah.
Memory.
I'm glad to. And before I do that, parenthetically though, I'll just mention in response to something you said that I think for a lot of people, what has happened is they really have experienced a trauma and they're living out, whether it's in their brain or in their bodies, they're living out the consequences of that trauma in the way that people do, but they don't necessarily have a label to use. They don't know that long COVID was a trauma. And
Right.
so, they're going to the doctor, they're feeling panicked as they're, heading to the clinic to get a test. They are having whatever symptoms they have. Those mental health symptoms feel often mysterious to them. And in truth, what's happening is they've been traumatized, right? They've been traumatized. Yeah. And it's useful often to suggest to them, hey, maybe this was a trauma. Maybe these symptoms you're having in your body and your brain are the same symptoms that that a soldier has, that a victim of assault has, that 101 people have after they're exposed to trauma. And I think when you view this through a trauma lens, that often is really empowering for patients, right? Because then they start to realize, oh, I'm not just going crazy, right? That's not what's happening. And you can help them understand. It's really useful. As it relates to the brains of long COVID patients, I think it's a little bit of a complicated story, and I think there's a lot we don't know. There are really two or maybe three categories of patients with long COVID. There are patients who had COVID who were in the hospital but never in the ICU. There are patients who had COVID who were in the hospital and in the ICU. Often those folks were on a ventilator. Often they developed other conditions like sepsis and pneumonia. Sometimes they develop something called acute respiratory distress syndrome, very problematic illness. And then there's a third category, the largest by far, and that category is people who were, as I noted earlier, just a little bit ill. I mean, they felt quite ill, but that is, they didn't require hospitalization, right? That episode of COVID lasted a week or 10 days or maybe even 3 or 4 days. So in all of those cases, what was going on in the brains of these patients was likely a little bit different. The cognitive impairment in the hospitalized patients, in the patients in the ICU, that's a little bit easier to understand. That is, they often have brain injuries due to hypoxia. They weren't getting enough oxygen to their brains. The inflammation that occurred in the context of sepsis was really profound. It damaged their brains. It's a little harder to understand what has happened in the brains of people who were never very ill. But again, we think often that there was probably an inflammatory process at work. There likely was a process at work in which the blood-brain barrier, which is protective of the brain, in the context of things like inflammation and infection, that blood-brain barrier likely degraded, became more permeable, so the brain was more affected by COVID than it otherwise would have been. I mean, those are just two explanations. But when you look at the research consistently, the findings are pretty shocking. You know, there's a famous study, newly famous. It was discussed first in an article in 2022 or so, and that study looked at patients in something called the British Biobank. I can send you this information. You can share it with your listeners.
Oh, great.
I'll try to make it really straightforward. Long before the pandemic, there were a few thousand patients, healthy normals, if we want to think of them that way. And they were evaluated every year, every couple of years. The goal of this study was to look at brain changes in normal people over time. They were evaluated with MRIs. And a British researcher, really brilliant, had a great idea, and that was, let's look at these thousands of people who already have brain MRIs. Let's figure out which ones of them developed COVID, and let's give them MRIs, and then we can have what researchers would call a pre-post design, right? We can look at their pre-COVID MRIs, we can compare them to their post-COVID MRIs, and I think most people, if you would have highlighted that approach, would have said, you know, we're not expecting the brains of these patients to be any different. We're not really thinking we're going to find anything. And indeed, when they did it, the pre-post design compared the before and after, there were really meaningful changes in the brains of many of these patients. A lot of them had atrophy in various brain regions. They had whole brain atrophy, which obviously is bad. Brains are shrinking, neurons dying, all of that. And that was a little bit of a wake-up call, I think, to the academic community, because an MRI is what we would consider a very hard outcome, right? If you're talking about a test like an MMSE or even a cognitive battery, those scores could be influenced by taking pain medication or being really sleepy or, 101 things, fatigue.
Right.
But an MRI is a hard outcome. So even when we use these hard outcomes, in a subset of patients, we see meaningful changes. We're trying to figure out how clinically relevant those are. That is, how much of a change do you have to have on an MRI before that's going to show up in your day-to-day life? Who gets cognitive problems? Who seems to be protected from them? These are questions we don't have answers to. But in general, I think it's safe to say that there are very significant numbers of people with very significant numbers of cognitive problems. And you made a point a little earlier that was a really astute one, and this is true with mental health. It's true with cognition. That is, we focus often, in the New York Times, in the Guardian, wherever, we focus often on the marathon runner who was in peak condition and what COVID did to him, or the high-flying executive who got their MBA from Wharton or whatever, what happened to them. And there are people like that. But there are huge numbers of people also who are already struggling a little, right? They already had some mild cognitive problems. They already had perhaps some anxiety. They already had some fatigue. So for those folks who are already vulnerable, this is like a tsunami, right? Like this is a tidal wave that has threatened to wreck them. And I think that's important because we often have focused on what does COVID do to the best and brightest, and we have ignored a different question, which is, what does it do to people who are already barely holding on, right? They're barely holding on. They're at the margins. For them, we see COVID being particularly devastating.
Yeah, you can see I'm very moved by what you're saying. And again, I'm thinking of a variety of people something you wrote, I'm jumping around a little bit, but something you wrote
Yeah.
in your book that I was so glad you included, because I think it's also important for family members and friends of people who maybe aren't struggling to get it. And your book would be so helpful for them as well, is this things that a lot of people think of as simple day-to-day things, like being able to take control of your finances, being able to earn an income when the income you were able to earn before was barely cutting it.
Exactly. Yeah. Yeah, it's particularly a crisis for folks in that category. We see some people, not a lot, but some, who were fortunate to have substantial financial resources, let's say, before. They were fortunate to have very meaningful social support networks before. Not surprisingly, those folks do better, right? Still difficult for them,
Yeah, of course.
but they can afford a plane ticket or two to fly to the Mayo Clinic, right? To go to the long COVID clinic there. They can afford perhaps to fly to San Francisco to check out a clinical trial that they are enrolling in. Recently, I was contacted. It's been a while, by a service, concierge medical service, and their entire job, if you will, and I don't begrudge it at all, but their entire job is um, patients pay them a lot of money, and then they try to find the leading oncologist or neuropsychologist or long COVID expert or whatever in the world that they can find, and they make arrangements for that patient to see you, right? And if patients have those resources, again, I don't begrudge it, good for them. And um, in the universe of people, right, that's a really small percentage, right? That's a tiny
Yes.
percentage of the pie. And the rest are often really left to struggle. I think what I've come to realize in long COVID, I'd known it before, but now I really know it, is how important social support is, right? How vitally important. We know this as psychologists, of course, but for people who don't have that, or for people who did have it, but political or other dynamics have gotten in the way, as in, you know what, I love you, son, but I don't believe in long COVID, right? It's not real,
Oh,
right? You're believing some lies here. Just take some ivermectin. When those sorts of situations occur and those longstanding bonds are broken and people are really alone, don't know what to do, it's quite a conundrum for them. And I think, I recommend mental health treatment so often for our patients, but what I'm sure you know and what I know, probably even more true in New York City than in Nashville, is that if you don't have insurance and if you don't have ample resources, finding a psychologist if you need one is really difficult. Not that long ago in Nashville, one of my patients with long COVID needed a psychologist. Actually, he had insurance. He had good insurance. And I gave him a list of 8 or 10 providers. And not one of them even took insurance, right? Because that's sort
yeah.
of how things are going. Here again, I don't begrudge that, but that's the reality for a lot of people, that there is a barrier after a barrier after a barrier after a barrier. And it really is, it's very difficult. Indeed, it's very difficult for them.
It's so true. Um, Long COVID makes everything that was already harder,
It
physically,
does.
mentally, financially, spiritually, everything. Something I wasn't going to touch on, but you brought up, and I think it's a good thing, and I want to be thoughtful about how I hold it.
Yeah,
Um, for a variety of obvious reasons, probably, is that public health has become so politicized.
it has.
And there's the misinformation problem where, everybody's Aunt Tilly is spreading something on Facebook that makes sense to them. And
Yeah,
maybe there's no malintent.
yeah,
But then there is the disinformation, which is just chaos making. And we are so polarized in so many ways.
yeah.
But also the people who are distrustful of healthcare providers, or Listen, I'm gonna say that I am somebody who is very interested in and apt to research complementary treatments.
Sure.
And there is some science to support some of the things I was going to ask you about in a little bit, like N-acetylcysteine for long COVID fatigue or vitamin D. I mean, there was something in the Yale Medicine newsletter on those things. And I think those are things that have other potential health benefits, and that
Yes.
makes sense to me. That's very different from, drinking bleach. you
Yeah.
know,
Yeah. No,
you
I
know,
think it's
it's
really,
hard.
it's really hard. And I think, part of what has happened, I mean, I don't, I'm
Yeah.
not a cultural analyst, right? So I'm aware of what I don't know, but I think this has highlighted how much culturally there is a sort of a disrespect for experts, if you will, right?
Yes.
And there's this idea that, um, yeah, my great uncle was a pharmacist, until he retired 10 years ago, and he told me that, these FDA approved treatments for COVID are a bunch of rubbish, right? Well, you don't want to put his opinion um, at the same level as you would put the opinion of the infectious disease doctor you see at Vanderbilt. With that said, um, all of us could do a better job, right? Communicating clearly,
Sure.
owning up to the mistakes we make. I think all of us could do better. What I have noted, what I have tried to do, I guess I would say, is as I interact with long COVID patients, mainly through these support groups that we lead. We have kind of a big family of support groups, people with long COVID, and I have tried really hard to earn the right to be heard by
I love
them
that.
in the spirit of people don't really people don't care how much you know. And this is kind of a bromide, but it's true. People don't care how much you know until they know how much you care, right? And I think week in, week out, week after week after week, as my colleagues and I engage these patients, and they see that we don't have any ulterior motive, we're not, out to benefit in some way from anything other than, hey, we really love you, we want to care for you, we're here because it's important, right? We get it. Then they begin to trust us, right? And then I think we have the right um, to speak into their lives a little more fully, right?
Yeah.
I'm careful not to recommend this, that, or the other. I know my limitations, but we do try hard to steer people away from the bad actors, if you will. From the people that are exploiting this situation. Physicians who will give you unproven drug cocktail and charge you, $500 for every phone call you make, and those sorts of things.
Right.
There are some people who've taken advantage of this, and most of us are trying hard not to. But I think the truth is, a lot of long COVID patients don't quite know who they can trust, and that's a challenge.
Sure. And in fairness to patients who are wary, and you're absolutely giving a nod to this. I think they don't understand how hard a lot of providers work to try to either engage in scientific research or to review it and keep up to date, which feels like an unbelievably daunting task.
Yeah.
Right. So that the work on their behalf goes well beyond the actual time spent with any one patient.
Yeah, I think
Um,
that's right. I think that's very true. I think if COVID patients, long COVID patients, didn't feel often so thoroughly dismissed in the context of the brief encounters they have with all too many physicians, I think they would consider a bit more, perhaps, what they're hearing. But often, the message they get from treaters who should know better is, that's just anxiety, or chronic fatigue syndrome isn't real. Don't you know that? That's been proven. Or,
yeah.
some variety of that sort of feedback. And I think, it's really it's really unhelpful. I think
100%.
as a profession, whether it is psychologists or whether it's physicians, I think we would do well to lead with a little more humility when we make a mistake, to acknowledge it, to admit when we don't know something. Right? We need to be better at that. I think patients would appreciate that. Right? I know with a lot of my long COVID patients, it's quite unsatisfying to say to them, I don't know. Right? Like I'm sorry, I don't know. Um, but I think they have quite a preference for that way of relating if you actually don't know, right? Like they can live
Right.
with, I don't know, we can walk on this journey of not knowing together, me and them together. We don't know. We're going to figure it out. But I think this sort of cocksure sort of a, hey, I've got it covered, I've got it figured out. Believe me, that way of relating to the patient, the sort of paternalism that still happens, it's really, really unhelpful.
Yeah. 100%. Totally agree with you. You mentioned chronic fatigue syndrome, and you mentioned in your book postural orthostatic tachycardia syndrome, otherwise known as POTS.
Right,
You mentioned long Lyme disease.
right.
Those are, I think it's so important that you mention those because there is this similar kind of phenomenon where providers and sometimes other people in patients' lives don't understand those either. Again, these invisible kind of illnesses, but that are very problematic. There's some thought that I guess long COVID is like those illnesses in a way. Tell me, do you want to talk about that a little bit?
Yeah, sure. I'm glad to. Yeah, I think they bear so many hallmarks, similar hallmarks, long COVID and long Lyme and chronic fatigue, POTS. They're very similar. They're probably related biologically, mechanistically in some way, but in terms of their clinical presentation, they're very similar. And I think in terms of their treatment, speaking as a psychotherapist at least, um, one modality that I have found works well with all of them, it's not a magic wand, is acceptance and commitment therapy, ACT. And what I love about ACT, Traci, and where I think it's relevant to all of these conditions is I feel like ACT is very empowering in the form of, yes, we'd love these to go away, we'd love these to get better, but we're going to teach you to find a way to accept and coexist with these things that are unwanted. And I think that's really important. I talk in my book about my own battle with OCD, obsessive compulsive disorder, and that started really pretty abruptly. One fall day in 2018, and it really kind of knocked me off my feet. And I went to see a psychologist, and I guess I would say I begged her, to fix it. And she said some version of, not so sure we're fixing this. Like I'll meet you in this hard place and we'll walk through it. I'll help you accept it. I don't know that we're going to fix it. And for really a couple of years, I guess I would say I treaded water waiting for it to go away. Right. That was the goal. I'm going to find a way to get it to go away. It's a very appropriate desire, but it got in the way of me doing something different, which was, hey, how can I get on the business with the business of living, right? How can I stop the business of waiting, get on with the business of living? And very often with our long COVID patients, and I understand this, I think it's not hugely helpful, but I think it's normal. Very often the way they frame things is they say, when my long COVID gets better, then I'll be okay. But I could never be okay until it gets better. And I'm really sensitive to that. I mean, I understand it personally as one with OCD, but I think the message is we're going to try to help you find a way to be okay with it, make peace with it, détente, whatever you want to say, even if it never goes away. Because if we're just waiting at the boat ramp for a boat to come, if that's what we're doing and it never goes away, that's not the rich, productive life that you're wanting.
Absolutely. And, again, the chronic pain comparison seems apt to me because it's
Totally.
the same type of thing. It's like, well, I'll go walk my child to school when my chronic pain goes away, and that may or may not ever happen, or it may be very different one day or one moment to the next. And how do you want to navigate that? But it's a hard thing to navigate. It's a hard thing to
It's so
sit with.
hard. It's so hard. And one of the things that I often focus on that is also a really hard thing to navigate is the following. That is often, and I did this with my OCD, often people who develop a chronic illness, chronic pain, or whatever it is, there's a little bit of a bright red line that they draw. There's their life before, there's their life after. And sometimes what happens is they imagine a life before that really didn't quite exist, right? Like that life before often in their memory was completely free of problems, right? And I think if we can say to them, yes, this is horrible, like genuinely, like this is so hard, and you've been in hard places before, and there's never been a time in your life probably when everything was perfect. I think that's really empowering. For me, recently, my OCD has been really mild. I think I would probably say that it has gone into remission in the last 6 months or so. So I'm grateful for that. But what's really interesting is I had waited and waited and waited and waited for that day that my symptoms would go away, if you will. And recently, I sort of woke up one morning and I thought, man, and your OCD, it's kind of gone away. And then I thought, gosh, you still have some problems. You still got some stresses. You still got some challenges. And I've reflected on that a lot. So I think if we can help our long COVID patients recognize that life before this insult, it is an insult. Life before this insult wasn't perfect, and life after can still be really rich. That's where progress occurs, I think, in embracing those insights, whether it's long COVID or whether, as you noted, it's chronic pain.
Such an important point. And as you were talking about, I was thinking of how many other things in our lives are like that, like grief,
Right.
like before someone passed, like, oh, how was our relationship tends to be idealized when it,
Yeah.
Clearly couldn't have been,
Right.
or, so many things where there's like that before and after demarcation in our minds.
Yeah.
And it's not accurate.
It's not, and I think one thing that is true. I mean, psychologists vary hugely, physicians too, in terms of how much personal disclosure they engage in. I'm
Sure.
very mindful of boundaries and pretty willing to tell my own story, maybe more than some, less than others. I don't think there's a necessarily a right and a wrong. There clearly are some wrong ways to do that, of course, but there's a range of ways to engage it. But what I do think is that the effectiveness that we demonstrate as therapists is sort of tethered, I think, to the work that we've done on ourselves, right? To the hard work we've done to address our own issues, right? And I think if I'm not comfortable myself living in this betwixt and between of, hey, it's beautiful and it's hard, right? It's really lovely and it's dark. If we're not comfortable living in that place, I think it's really going to be difficult to invite our patients to live in that place. And I think that's what we should aspire to: address our own issues, and in so doing, we're going to be better able to give patients with long COVID or whatever the issue is what they need. But that's linked a little bit to how much we're working on these things ourselves.
Absolutely. Such a great point. I want to you do such a great job in your book about talking about how we can live with long COVID and honestly many other things. So I think this is a great time to kind of talk about that. I'm just looking at my million notes, and I'm old school, so I print them out and they're on paper in front of me.
I got it. All good.
But you talk about a lot of the things people can do. You did talk about ACT in the book. You talked about referenced Viktor Frankl, which I love, about finding meaning.
Yeah.
So important. And you spoke about compensatory approaches, especially for things like, some of the cognitive changes that kind of go hand in hand with long COVID. I wonder if you want to talk about some of the things people can do to feel better now rather than, and to function better now.
Yeah. I'm glad to. It's such a great question and a comment. The first thing I would say is, it's hard to do this work that is navigate and find your way. It's really hard to do it alone, right? It's really hard to do it in isolation. You don't have to have 100 people pulling in your direction, but you need a few at least, right? And if you don't have them, I get that it's not necessarily that simple, but if you don't have those people, try to find them, right? Wherever you can find them, try to find them. We have a support group, people can join it, and they find each other that way. But find some people to support you in your endeavor. I think that's one thing. Trying to do this alone, it's not really a solo sport, coping with long COVID. I think these compensatory strategies are really important. I think as we think of cognition, often they are a difference maker. The way that I have thought about this, long thought about it, is that for many people, not everyone, but for many, cognitive problems after COVID really reflect a brain injury, what we would call a mild acquired brain injury. And if a patient has an acquired brain injury, this sort of standardized approach that you would take, the standard of care approach would be, you're going to see a speech and language pathologist. And they're not necessarily going to get a magic wand out of their toolbox and say abracadabra and fix your brain, but they are going to give you some tools that you didn't have before to cope. And those tools often are things like, we're going to teach you to be a little more aware of the situations where you're likely to make mistakes. And now that you know where those situations lie, you can anticipate them, right? If you know that you're prone to losing your keys when you're stressed and hungry and angry and in a hurry, when you're feeling those emotions, that's where you need to make sure, man, today I'm putting the keys in, right? If you are unsure now because you have executive functioning deficits about how to log on to Zoom, you need to show up for the meeting 10 minutes earlier than you normally would, right? So you can give yourself 10 minutes to figure it out. Those sorts of things, often very practical. And when patients do those sorts of things, often guided by a professional, either an occupational therapist or a speech and language pathologist, not surprisingly, they do better. So I love compensatory strategies. I think there are other things in the mode of self-care that can be really valuable. Immersion in nature, I think, is really important, right? A lot of ink has been spilled about this topic. I'm not sure that it will fix a severe case of major depression, but I think if your mood is misaligned and a little bit altered, I think it can be a hugely effective thing to do. For our long COVID patients who don't battle with fatigue, I think exercise can be hugely helpful. Now, that's a little bit loaded because far too often with patients with CFS or long COVID, the guidance is exercise your way out of this. And I think that's not necessarily helpful. But a lot of our patients don't have primary problems with fatigue. They have problems with balance, or they have cognitive problems only. So if you're in that group, exercise, I think, is fine. Participating in community is really important. And I think generally, and this isn't so easy to get, some people arrive here easily, some less easily, but generally trying to develop a stance of openness to possibilities, I think it's hard to overstate how important that is. I'll just share one quick anecdote. That is, we have a support group for spouses of patients with COVID who were in the ICU, and we have a really dear family in our support group, a wife of a long COVID survivor. They live in the South here, and she and her husband are big football fans, and they wanted recently, badly, they wanted to go to the Ohio State Tennessee football game, and he has to use oxygen. He has an oxygen concentrator. He has to carry it around with him, and he badly wanted to go. His wife was really afraid. Evidently, the oxygen that you use degrades a little bit in cold weather. They were going to be outside. And so they initially closed the door on the possibility of going to this game because, hey, it's scary, it's risky, the oxygen isn't going to work in the cold weather. Anyway, all that to say, instead of firmly closing the door on that, they left it open just a little. They contacted the company that made the oxygen machine. They found out that there were some workarounds that were available. They contacted the athletic department at the university. They found out that in an emergency, there were oxygen tanks in the stadium. It would be a little scary, but they could get to them. Long story short, they went to the game. They loved the game. It was one more example of this gentleman and his wife who are so dear, pushing against self-imposed limitations. Now, these limitations, they don't arrive casually. I mean, these are meaningful. These things are scary. But many of our patients, I would say consistently, find that they can do a little bit more than they think they can. And if they try these things, I mean, I never want them to be reckless, of course, but if they try these things and they find out they can't do them, that's also useful information, right? It's useful. Okay, I'm not going to try that again. I'll try something else. But until you try it, again, not casually, I mean, with support, with some guidance, until you try it or not try it, it's an open question whether you can go to the county fair, whether you can make that trip to Europe that you want to do, whether you can walk in the 5K, whether you can return to work. Until you try, it's an open question. I'm a big fan of Brene Brown, as maybe you are, millions of people influenced by her work. And of her many quotes, there's one that I love the most, and that is, you can choose courage or you can choose comfort, but you can't choose both. You can have courage or comfort, can't have both. And I think reminding our folks that, the growth that you want to engage in often comes at the edge of that comfort zone, and that to get to the place you want to be, you need to be willing to move in a place that doesn't feel good to you all the time. That's a really important message, I think.
That was so incredibly well said. I really just so profoundly helpful and well said. This whole interview honestly was so so helpful and so informative. And again, I'm so grateful that you made time out of your extraordinarily busy schedule to be here. I think it's going to help a lot of people. Jim, is there anything I didn't ask you that I should have, or anything that you want to mention? Well, definitely mention your book and where people can get it, and
Sure.
anything else you want them to know.
Yeah, there is. I would say one thing. I would end on a little bit of a hopeful note, and I think people use the phrase. I didn't know this was even a word. There's a word, hopium. There's a related word, toxic positivity, and I don't want to be about that, right? Like, this isn't about rainbows and unicorns, running across the pasture. It's not all happy. This is hard. And with that being said, over time, we really do see people with long COVID get better. We see a lot of people get better. And I think if we can invite people to be open to the possibility that that could happen, it might not happen, but it could. I think that's really important. Change and improvement takes time. It's not a linear process by any step. Often it is, 2 steps forward, 9 steps back. I mean, that's the reality of it. But often with time, we see people getting better. I got an email from someone even today that had indicated they really felt like they were improving. And I think those stories probably aren't talked about quite enough. If you take my OCD as an example, it's been 6.5 years since I developed it. Long time. 6 years later, I feel like I'm finally getting quite a bit better. You have seen patients, and I'm sure I have too, who try an antidepressant for 3 weeks and they say, this isn't working. Or in marriage counseling, a husband and wife, they try 2 times and they say, this is a waste of time. And I say, it's going to take more than 2 times. It might take 200 times, right? So the problem with our long COVID patients, to be sure, isn't a lack of effort. It's not that they just need to do things 200 more times. That's not my point at all. But I would say this, every Sunday at church, there's a benediction at the end of the service. And in that benediction, you stand up and, you hold your hands out to receive whatever in my denomination, the pastor has to say. Gives you a blessing, you receive it. And we really try hard to foster this stance of, let's keep your hands open every day. Let's be open to the possibility, yes, that you're going to be where you are, but let's also be genuinely open to the possibility, with hands open to the possibility that this could get better, and that even if it doesn't get better, with support, we can help you find a way to live a meaningful life. So I'm hopeful. It's not hopium. It's not toxic positivity. We genuinely see people get better. And if people are listening to this podcast who are struggling, I hope that's their story. But I know, what I do know is that even if that isn't their story, natural recovery, there are ways to find a way not just to survive, but to thrive with one.
Beautifully said. Beautifully said, and so true. Jim, where is the best place to get your book? And is there a website you want people to be referred to for information on the clinic? Or I don't know if the clinic's accepting new patients.
You can buy the book on Amazon. You can also buy it at Barnes & Nobles. Those would be the 2 obvious places. There's a clinic we have at Vanderbilt. If you Googled the ICU Recovery Center or the Vanderbilt CIBS Center, CIBS Center, you'll find me. If somebody wants to send me an email, I'm always answering them. I'm writing a second book. That book will come out a year from now, and I'd love to be back with you. And I think that'll be useful. But if people are intrigued by what I had to say, and they've got questions about long COVID, they want us to refer them to a resource wherever that would be, or weigh in on this or that. We don't give medical advice, but if we can be an advocate, help support somebody, that's where our heart is. So they're free to reach out to me.
That's amazing. And I'll put links to the book and to your website in the show notes. Jim Jackson, thank you so much. I went longer than I said I was going to keep you, but you had so many important things to say. It was really such a pleasure.
Yeah, thank you. Let's stay in touch. I'd love that.
Please, that would be great. This has been another episode of Unpacking Possibility. If you enjoyed the episode, and I know you did, please remember to like, share, follow, leave me a comment. Let me know what you think. And as always, until next time, be well.